Hello everybody. Thank you for joining us virtually. We have here Dr. Scheuring, who is probably one of the more, or in my opinion, one of the most interesting guests that we've had come on here. I'll leave it to Dr. Scheuring to give himself a brief introduction. We'll kind of dive right into questions and get a better understanding of what it's like to be a flight surgeon.
All right, well, thanks for having me. Sorry, there's been so many delays with getting together. We just finished the 65S year-long U.S. ISS mission, and there's a lot of operational and medical challenges in it over the last year. So anyway, it's nice to be done with that, and we're kind of what we call the reconditioning phase. Manned spaceflight is comprised of three phases: pre-flight, in-flight, and post-flight. A lot of people just think about the spaceflight portion, but there's actually quite a bit of prep that goes in where the flight surgeon is supporting all the crew training, the crew medical events, the crew medical training, the certification process that we have to present before the medical boards, before the international boards. All these things have to happen before they get to flight, and then you launch them into space, get them into space, then you do the space thing, and then start preparing, usually about 4 to 6 weeks out from landing, for reversing the whole process and going getting your crew, and then that continues for about 30 to 45 days after landing, where you're working with them every day, reconditioning, doing all their post-flight studies, et cetera, et cetera, et cetera. So every morning I'm in the gym with Mark Van High at 6:30 in the morning, and we're working on his neurovestibular readaptation, his strength, his stamina, his agility, flexibility, all these things that take a hit in microgravity, but it really depends on that crew member. Some crew members, it takes a while for them to kind of get their sea legs back. Other crew members, we've been kidding around that Mark never went to space. They locked him in a room, spent a year in the room, and then they unlocked it and let him out right at landing, and we brought him back. We're like, this guy never went to space. It's kind of like that really, really bad O.J. Simpson movie, Capricorn 1. Did you guys ever see that movie?
I have not seen that, no.
Horrible movie, but it's really funny.
Okay.
It's supposed to be serious, but it's really funny, where the first Martian crew, unbeknownst to them, it's all a farce, and they show the launch, but actually they go into a room in some desert and they just fake the mission, but the crew really wants to do the mission, so they're trying to get out, and this is kind of like that. This is Capricorn 1, the Van High version. It's the
Van
sequel.
High edition. Okay.
So as far as my background, so I went to Chicago Osteopathic back in the late 80s, early 90s, back when it was called the Chicago College of Osteopathic Medicine, before it switched over to Midwestern. And then I went and did an FP sports medicine residency out at Denver Press St. Luke's, and came back to Illinois in 96 and set up my own family practice, sports medicine practice in Galena, Illinois, and practiced there about 6.5 years. And then 9/11 happened, decided to get in the U.S. Army, and then really had a good long look in the mirror and said, you know what, I don't want to do family practice in a small town the rest of my life. I want to be a space doctor.
Excellent choice.
I mean, it was crazy because I didn't know anything about space. The only thing I remember seeing was there was an ad in the back of the New England Journal of Medicine back in 1996 for a space medicine fellowship at UTMB under Tom Blackburn. To this day, I've never met Dr. Blackburn. But I'm looking at this and I'm like, what's this really cool? So I called up UTMB, and Dr. Richard Jennings was the program director back then. And his secretary said, are you in the military? At the time I wasn't. And said, have you ever published anything in space? I said, no. He said, what, did you fly? I'm like, yeah, I'm a private pilot. He's like, okay, call us back in 6 months. Call back in 6 months. Are you in the military? No. Have you published anything in space? No. And that went on for about 3 years. And I finally realized they're not interested in me whatsoever. So yeah, I put that aside. My wife and I decided to have lots of babies. So we had 5 kids, living a couple acres in the country. It was a great life. Then 9/11, like I said, happened. That forced my hand. But then I thought, you know, this is kind of a watershed moment. Did some more digging around. And again, this is 2001, 2002. So there's, you know, yeah, you had the internet, but it was still somewhat limited in terms of information. And there was certainly no education outreach about aerospace medicine. But I figured my best chance to learn about the field was to go to the ASMA conference, the annual Aerospace Medical Association meeting. And that year was in Montreal, Canada, which to this day, I've been to 21 ASMAs. That probably is one of the best ones still. Went there, spent the week, got to meet all the people, and I brought my wife with, and I'm like, yep, that's what I'm gonna do. Got in the right state program the next year, and halfway through my second year, Wiley, KBR, hired me as a contractor flight surgeon. So the residency let me go, provided that I would get my master's degree finished and then graduate, which I did. And then I worked my first 3 years as a contractor as an advanced projects flight surgeon for KBR Wiley. And then in 2007, a civil servant job, the NASA flight surgeon job came open, and it was specifically for a flight surgeon who was well-versed in Apollo lunar missions and lunar surface operations with intimate knowledge of lunar spacewalks, et cetera, et cetera. Well, my boss, JD Polk, who's the chief doctor now at NASA in Washington, D.C., told me in 2005 when the Constellation program came online, that was the first return to learn program. He's like, hey, we're going back to the moon. We got to learn something about the moon. Why don't you spend the next 6 months researching everything you can about Apollo? So that was my job for 6 months. I spent 10, 11 hours a day just reading everything I could about Apollo, the moon. And then I came up with 285 questions that, to my best of my knowledge, through reading all the debriefs, all the mission logs, everything, had never been asked about human health and performance. So I sent out an invitation to all the surviving Apollo astronauts, and I got 81% response, and they came for 3 days. So I spent 3 days with Gene Cernan, John Young, General Stafford, Harrison Schmidt, all these guys. Here I am, a couple of years before that, I'm a family doc in a small town. Here I'm working with my, the legends.
Right.
And for 3 days, I just picked their brains, and they helped me come up with 107 recommendations for improving health and performance for the return to lunar mission. So I published that, went on a road show, published it after Astronaut, wrote a 400-page technical manual, and that was kind of my ticket into NASA. So I showed NASA why they need me. That's how you get into NASA.
Yeah.
All the docs that apply are outstanding, way smarter than me, which doesn't take much. But you got to show NASA why they need you. Why do you have a special skill that NASA can use? And that's kind of the one thing I really kind of would get out to folks watching this is think about something you love, get really smart and good at it. And then if it applies to what we're doing in space, then do the aerospace medicine clerkship at NASA when you're a fourth year med student or a resident. Be tenacious, persist in your dogged pursuit of setting yourself apart, and then just be a good person, to be a team player. That's I've mentored probably 100 students since 2006, and the students I've seen that eventually come on to be NASA flight students were just good, kind people who are team players. May have been like me, not the smartest guy in the room, not the sharpest knife in the drawer, but could get along with people and interact with teams, because space flight's a team sport.
Right.
There is a place for super scary smart people who can't relate to people, and they put them off in the research side. But if you want to be an operational doc, work with the astronauts, do these missions, and being in the military helps quite a bit. It's not a requirement. There's plenty of NASA flight students who have no military background, but it was very symbiotic for me to be doing the Army, being deployed, going to Iraq, doing all that kind of stuff, defending freedom. At the same time, I'm marching along to the NASA career. So if you've seen one NASA flight surgeon story, you've seen one NASA flight surgeon story. They're all different. They're all unique and very interesting. I'd say probably the majority of the 15 or 16 NASA flight surgeons are emergency medicine. A few of us are family practice. I was the only one with sports medicine background, which turned out serendipitous because by about 2010, my boss, again, Dr. JD Polk, was now our division chief. He had graduated up from the branch chief to division chief. And he's like, hey, Rick, we got all these orthopedic injuries. Hey, you're an orthopedic guy. trying to figure this out. So I actually, so I've been in NASA 6 years. I'm like, wow, I'm actually doing something I finally know something about. And developed the musculoskeletal medicine and rehab program at NASA in 2010.
Okay, wow.
So I started bringing down in Houston, at the Houston Methodist, we have the orthopedic surgery sports medicine department. So we have board certified orthopedic surgeons who are doing a 1-year sports medicine fellowship in orthopedic surgery. I started bringing them down to NASA every Wednesday to help me run my orthopedic clinic. In and around this time, I actually did a 2-year muscular ultrasound fellowship with Tony Buffard up at Detroit Medical Center. So every week for 2 years, I'd fly to Detroit Medical Center, do tons of muscular ultrasound, fly back to NASA, practice on the astronauts, go back up there, do back and forth, and then do all the didactic work. And then in 2013, I took the first board exam in muscular medicine, passed it, and been doing ultrasound ever since. So I teach the orthopedic surgeons how to do ultrasound, which orthopedic surgeons initially were not very interested. They're like, we got an MRI. Why would I do ultrasound? You know, ultrasound's kind of a better tool. You know, if you're on the sideline, if you're, you know, deployed, if you're on a helicopter, if you're in space, that's the only thing you have to use is ultrasound. And they drank the Kool-Aid, and I've trained, I think, probably about 18 orthopedic surgeon fellows, and they've all passed the board exam. So that's really pretty cool, because they're the only orthopedic surgery program in the country that gets to work with astronauts and gets their board eligible for muscular ultrasound. So anyway, started the muscular program. So I was really utilizing a lot of my skills there, but all the way doing shuttle missions and then doing ISS missions and publishing a lot. I like to write, so I published a lot on muscular stuff, different whatnot. And then and then 2 years ago, they offered me the ISS PMO job, which is the ISS Program Medical Officer job. So basically, I'm the flight surgeon, kind of oversees all the risk management for the ISS program and kind of co-lead all the ISS flight surgeons, make the flight assignments among the flight surgeon, and then really try to mentor up the brand new flight surgeons and try to guide them through the whole process of becoming certified as an NASA flight surgeon to work on console mission control and then do missions and all sort of stuff. So that's been a fun job. So, yeah.
Awesome.
And then I manage all the EVA injury stuff, so I still work that. And
nice. Okay.
So anyway, I don't know. Is this all boring everybody to death? I mean,
no, I'm so bored. I've not been listening with any interest. I'm kidding. This has been fantastic. It's really cool to see how different people get into a position at NASA or as a flight surgeon. Like you were saying, if you heard one flight surgeon story, that's one flight surgeon story. You know, it's very different. Now you mentioned that you've gone to Midwestern, and so I'm from the Chicago region, and I actually toured Midwestern and, you know, really liked it and all that. And I do understand that, you know, osteopathic students undergo extensive training in OMM. Right now, you're a sports injury doc, and you do a lot of musculoskeletal stuff, and you're working with astronauts. So, just out of curiosity, have you been able to utilize any of your OMM training with these astronauts post-flight, or what's that been like for you?
Yeah, I've used muscle energy, counter strain, cervical traction, for the most part. I don't really get into a whole lot of cranial sacral stuff, but this past August, we got an Air Force DPT, who's fellowship trained in manual therapy. She's a active duty Air Force, who is a rock star. She was embedded with special forces, amazing. And it took me 5 years to get this agreement with the Air Force Academy to get this DPT assigned to NASA under the Space Force. So something's going on in the background. But anyway, we got Major Anderson here, and she's been doing all the hands-on manual therapy stuff now because she's really good at it.
Gotcha.
And that's her primary job. I have like probably 10 different jobs at NASA. So that, you know, and the way the astronaut clinic works and the astronaut gym is it's concierge medicine. The astronauts, when they come in, they get treated. It's not like they were making appointments and working around your schedule. You just got to be there, and someone says, hey, yeah, my shoulders bug me, can you see this, whatever, and she's always there. So she's doing it. And that's worked out pretty good. We have done OMM in space
Mhm.
with some really good results from the crew. But OMM is hard in space because a lot of our techniques depend on gravity.
Mhm.
So you have to actually create artificial gravity in space by keeping them bungee down or doing different things. So it takes some creativity to do OMT.
Mhm.
Simple things, like again, like counter strain, which is very easy to do, on Earth, is actually really hard to set up and do on orbit because in microgravity, every action has an equal opposite reaction. So
Right.
that's not what you want. You want them to hold still and then do. So it's been very interesting.
Okay.
But
Excellent.
anyway.
Solid. And so you mentioned that you had, gone with the Army post 9/11. You've been deployed, or deployed, and all these things. So were you part of an HPSP type program, or was this after you had become a physician? You decided to enlist, and then you kind of went from there. Was this like?
No, I had no prior military experience. I think, what was I, 38 or 39 when I raised my right hand and commissioned as a captain in the U.S. Army. So
Gotcha.
nothing.
Okay. Yeah, and I bring that up because, Lauren and I are both pre-med students. I'll be going to medical school in the fall, and that's one thing I was considering was doing HPSP. And my whole, you went Army, I was thinking about going Air Force, and I was considering HPSP. I talked to a few doctors that had gone down the HPSP route, and what the conclusion I personally had come to was I was going to go through my medical school training, go through residency, and then go through the officer training program into the Air Force, and then kind of go from there. So similar to what you did. So it's kind of reassuring to hear that it's probably beneficial if you kind of get into the military a little bit beforehand, but it's also possible if you go further down the line. I was considering also going through USIS and all that, but it's really, it's good to hear. There's different paths in that are helpful.
Yeah. Well, I'm actually in my reserve capacity now. I've been an associate professor of military and emergency medicine at USIS now since I got back from Kosovo in 2015. So
Okay.
I'm a big fan of USIS.
Mhm.
But as far as HPSP, my youngest daughter Anna is a first year at ASCOM,
Okay.
and she got the Army HPSP scholarship.
Solid. Okay.
I'll tell you, that is a winning lottery ticket, and you have more flexibility than you have at USIS. USIS is a world-class medical education,
Definitely.
hands down.
Yeah.
It's very hard to get into. If you can get in there, go for it. But if you don't, the HPSP, highly recommend the HPSP because you get second lieutenant pay, which I think, at least in the Army, an O1 makes, I think, about $67,000 a year.
Mhm.
Everything's paid for.
Mhm.
You'll do basic, you'll do some other stuff between your first and second year, and then you'll basically owe about a year and a half per year. So I think Anna's got 4 years of active duty followed by 8 years of reserve. So it's a 12-year commitment, but that time goes like instantly.
Okay.
You'll have no debt. You will have gotten to be deployed to do just incredible medicine with really interesting people. It doesn't necessarily slow down your NASA flight surgeon process because you've got to go do a primary residency. You got to go do the RAM somewhere.
Right.
And space today, if you look at where we're at today with space, which is completely different than we were even 2 years ago, because now we have SpaceX doing missions. Hopefully Boeing will be online. You've got the PAM missions, the private astronaut missions. So right now Axiom's up there with 3 billionaires. The ISS is turning into a bed and breakfast for billionaires. The Japanese billionaire flew up there in December. In October last year, a Russian movie director filmed a movie called The Challenge up there. And space is becoming great. So the point is, jobs are just going to go crazy. And combining military, where you get the operational experience, you become a very good practitioner. I'm a family doc, but in Texas, I actually moonlight as an emergency physician. I can work in emergency rooms because in Texas, if you've got, I'm an ATLS instructor, I'm military, I do military medevac, do all that sort of stuff. Even though I'm a family doc, in Texas, they're like, yeah, you can do emergency stuff.
Right.
It's fine. Other states have their own rules, and you got to be board certified in emergency medicine, whatever. But yeah, the military gives you a foot in the door for all that. if you, I can't say enough about the HPSP or uses if you can get into uses, but uses is hard.
Uses
So-
is hard. Absolutely. Great. And so you had shared before that, you'd worked with some of the Apollo era astronauts to kind of develop, based off your 285, I think, questions, you developed some recommendations. Could you share a little bit about what those recommendations were and maybe how NASA is working towards them or preparing to work towards them, or what that's kind of like?
Well, the bulk of the input and recommendations had to do with the EVA suit, so the
I see.
space suit,
Okay.
and how the human interacted in it, how the A7LB, which was the name of the Apollo spacesuit, was very limited in its range of motion in the upper extremities and in the hip and the spine. That's why they kangaroo hopped,
I see. Yep.
because they didn't have the mobility to actually walk on the surface and all these different things. So, they gave us recommendations for improving visibility in the visor, to be able to improve, range of motion in the shoulder, degrees of freedom in the hands, to get a mobile waist ring, a hip ring, to be able to do all these things to have greater mobility. So those are a lot of the recommendations, and we have incorporated that in the new spacesuit we call the XEMU, which means Exploration EVA Mobility Unit.
Okay.
Gave us a lot of recommendations about exercise. All they had was something called the Apollo Extra Genie, which you can actually go to eBay and still buy the Apollo Extra Genie. But basically, it was just a band in a flywheel device, and you basically just did this.
Yeah.
But the crews loved exercising because translunar and trans-Earth coasts were very boring. I mean,
see. Yeah.
basically just
Kinda coastal.
sitting there.
Yeah.
Trying to pass the time, hoping nothing goes wrong, like Apollo 13.
Uh-huh.
And so the crew really liked exercise. Now, our exercise today is orders of magnitude better than what they had in Apollo. And Apollo, when they heard what we have in the space station, were like, yeah, that's amazing. So you're going to want to exercise. So they really emphasize that. They didn't have a lot of insight in terms of whether or not 1/6 Earth gravity on the moon provided enough aerobic and resistive load to actually maintain fitness. They thought that it did, but when we actually looked at their biomedical data, their met rates and stuff, it really didn't. So we would probably need an additional exercise device to maintain bone, muscle, et cetera, et cetera. But one of our biggest challenges, and we're trying to develop a product where, let's say you're the first, return lunar astronaut. A couple of years from now, you decide, screw medical school, I'm a stud Spartan. I'm going to go to the moon, and NASA says, oh yeah, we want you. You're a Spartan. 300. Hoorah. And you get to the moon. Everybody's neurovestibular readaptation to a gravity environment is different. So the challenge for the flight surgeon is to figure out when you basically are going to be safe to go out the hatch. Will it be 6 hours? Will it be 12 hours? Will it be 24 hours? Will it be 36 hours? Apollo was only 4.3 days Earth to the moon. The Artemis 3 mission is probably going to be up to 21 days. And we learned from the long duration shuttle missions, there's a huge difference in neurovestibular control between, a 6-day mission, which has very little perturbation in neurovestibular control, and a 20-day mission. Huge changes. So it would be very, very foolish and very risky to just say, after you land on the moon, like they did in Apollo, I think Neil Armstrong and Buzz Aldrin got on the surface maybe within 6 hours of landing on the lunar surface. And they did that, and they did okay for their first 3.4-hour EVA. You're not going to be able to do that if you spent 20 days in microgravity. So we got to figure out a really good neurovestibular screening tool to do a quick assessment and figure out, are you safe to get in the suit and go out the hatch? And the program is really, really interesting in that, because they're sending you there. The initial Artemis 3 mission is, I think, 6.5 days on the lunar surface. They want you to get out on the surface and start doing stuff.
Right.
if we have to spend a day for you to adapt to 1.6G, so you're not, at risk for falls and injury, yeah, we could probably find something for you to do. But one of the things we learned from Apollo was, do 2 EVA days and have a day of rest. Do 2 EVA days, day of rest. It's just so physically and mentally taxing. You have to have a rest day in there.
Gotcha.
And, the program looks at that and says, well, if we're on the moon, that's costing us a lot of money. We should just work straight through. And I'm like, you can't do that. You're gonna break things. There's gonna be risk for errors, risk for injury, et cetera, et cetera. Apollo told us that. They said you have to have, a break in there. So anyway, a lot of it's gonna tie into, again, when you're good to go out the door based on this neurovestibular screening tool that has yet to be developed. And then really just listening to the crews. And the problem with the crew sometimes is they're their own worst enemy. And the flight surgeon job is to protect them from themselves. Because they're going to tell a program, I'm always good to go. I always want to go.
Yeah.
But then you're talking to them in the background through your private medical conferences, and they're like, I am really tired.
Yeah.
I'm not sleeping well, whatever. And yet they turn around and tell the program, I'm great. I'm ready to go. And then you have to wear the black hat and say, I know they said they're okay, but it's not a good idea. And then you get pitted between the program saying, do it, and the program saying, I want to do it. And you're saying, it's not a good idea. And oftentimes you lose, but when you win, it's big. And it's all about protecting the crew. I don't get any points for this. So
you should get some credit. One question that kind of popped in my head about the neurovestibular perturbation. So is that something that's progressive? So you were saying, it's over the course of 21 days, do the perturbations kind of increase or additive over the time, or you just kind of get to a point and it just kind of plateaus there?
it actually, if you look at, because there's some very elegant studies that were done during NeuroLab with all kinds of different reaction times to balls being thrown at you in different velocity and stuff like that. It actually hits a clinical threshold at about 2 to 3 days and then drops down and then subclinical, and you adapt very quickly. Okay. So it's only a few days and then you're normal for space.
Right.
But when you return to a gravity environment, then it's usually a couple days to readapt, and it's different for everybody. I've seen some crew 3-4 days after their return, you have them do something like a tandem walk, or you do the drinking bird thing, or do anything off balance, and they fall right over. I've seen other crews who come back, and like I was just saying, they never look like they went to space.
Shut them in a room.
And there's no way, and there's no way to really kind of screen and predict who those people are going to be.
Gotcha.
And that's kind of the mystery. I did my master's degree in spatial disorientation and fatal degenerative aviation accidents. I'm fascinated by neurovestibular function. It's an amazing design. But we just still don't know who's going to have a problem and who's not going to have a problem. So all you can do is really try to diagnose the extent of the problem, and then try to track what their readaptation is to be able to go and do something very, very neurovestibular challenging, like getting in a spacesuit that has a high aft center of gravity and not topple over. It's hard.
Yeah. And so you'd mentioned pre-flight screening in terms of fitness. It's hard to do it for neurovestibular stuff. In terms of overall fitness, what's that like? So we had talked to a few other individuals that were involved with NASA and getting astronauts prepped and all these things. And the impression that we had gotten was that NASA is very comprehensive in how it screens for its candidates, right? So they have excellence in maybe engineering, they can speak Russian, they have a lot of, they're a team player, they're very collaborative, they're very humble. Where does physical fitness fit into that? Are you screening for astronauts to be physically rigorous before they go into flight, or what's that like?
I can't say.
Can't say. Okay. That's fair.
Just be really in good shape.
Okay. Be fit. That works. It's good enough. And another thing that popped in my
But you don't have to be an Olympic athlete. And believe me, I've seen Olympic world-class athletes come through and not get selected. So being a physical specimen of incredible strength or stamina doesn't necessarily buy you the ticket. as an NASA flight student, I have no insight into how the final decision made. That's made with the astronauts behind closed doors.
Gotcha.
All I do is the medical screen. So I do all the orthopedic evaluations and judge whether or not you meet the standards in our particular area: cardiology, neurovestibular, ophthalmology, ENT, orthopedics, et cetera, et cetera, et cetera. And then we offer up to the astronaut corps, this individual meets all the standards, or this individual does not meet this standard. And on astronaut selection, there's no waiver. So you can't get a waiver for selection. Once you're an astronaut, we will waive medical conditions because medical conditions occur.
Right.
But on astronaut selection, you can't get waivers for anything. So you have to be really fit, really healthy, et cetera, et cetera, et cetera.
That makes sense. And so what role does, radiation in space kind of play for astronaut health, basically over a long term? I understand it's for longer term missions. If you're going to be going to Mars, it's a significant factor. But for missions to the moon, NASA's aspirations on the moon, where does radiation kind of play in there?
Well, we have NASA's engineering environment. Everything has a requirement, and we have requirements for, the cumulative, radiation dose you can get before you can't go into space anymore. I can't tell you what those are, but basically an astronaut is considered a radiation worker. So if you look at what a nuclear power plant worker is, we're bound by the same kind of ALARAs, as low as reasonably achievable. You can't increase your lifetime risk of cancer more than 3% from your job.
Right.
So in low Earth orbit, we're shielded by the Van Allen belts, so the radiation doses for an individual, relatively speaking, are fairly low for 6-month low Earth orbit missions. But for Moon and certainly for Mars, they're going to be much higher. So we're going to have to figure out either our shielding is going to have to be much better for those missions outside the Van Allen belts, or we're going to have to change our risk posture and accept more risk for lifetime cancer. I don't know how it's going to play out, but Moon will definitely buy more risk, and Mars is certainly going to buy more risk. So that means either you put more mass power volume expenditure in your radiation shielding, which means then something else can't go. It's like balancing a checkbook, right? You only get so much mass power volume. And if you've expended on having a really great radiation shield, that's great. So you've bought down all your risk for radiation, but now you can't do anything else.
Right.
So versus saying, well, you know what? If we decide to fly at solar min, right now we're in solar max, there's 11-year solar cycles, maybe our risk will be low, and we can get away with not frying anybody with protons through a big coronal mass ejection. So I don't know, but yeah, radiation's a big deal. One thing as an NASA flight surgeon, I certainly didn't get this in medical school. I don't know about you guys, maybe you do today, but when you come to NASA, you kind of become a default radiation health officer. When you're sitting in all these engineering meetings, every morning I have to report on what the sun's doing, what the space weather activity is like that day, what's the geomagnetic risk, what's all these different risks playing in. I don't learn that in med school. You got to learn that.
Yeah.
Now, we have a team here called the SHRAG, the Space Radiation Analysis Group. They're all radiation physicists and super cool spidey sense dudes who that's what they do. A lot of them from the military, and they tell us exactly what's going on in the geomagnetosphere, on the sun, the heliomagnetosphere, and then we kind of get to interpret, how this plays into, our risk posture and our requirements, keep the astronauts safe, and that's one of your jobs. Wow. So I think radiation, if you want to find that niche that shows NASA why they need you, boy, if you're a radiation physicist or you're a physicist, and then you became a doc, and then you're something like that, and you got really smart in that, boy, that'd be a pretty cool ticket, because none of us are specialists in that. Now, some of us really take an interest in it. I personally find it fascinating. So I've gotten, I think, smarter than, others, just because I really spent a lot of time with it. And I've worked missions during solar max where we had a lot of solar activity, and our crews had to take safe haven in the crew quarters, during very, very high geomagnetic activity and different things like that. And the program expects you to interpret all this data, and you got to figure all this stuff out with the help of the Schrag group. And so it's just very interesting.
Yeah, I might have to make a pit stop and get a master's in nuclear physics and finish my
Well.
MD. That'd be interesting. Cool. So you were mentioning you have to balance. You were calling it mass powered volume or something like that, where you have to decide, what you want. You can either max out your protection against radiation, or you can do X, Y, Z. But you mentioned that ultrasound is one of the tools that gets sent up to space. And one thing that we learned is you get a very limited amount of space to pack your medical supplies. And so it's a real balancing act of what goes in there, what doesn't go in there. So, you probably definitely can't get into the details, I would expect, but what is a decision like? So, I mean, if you're trying to set up antibiotics, right? How do you know which one to send? You're a sports medicine doc, do you advocate to send kind of materials that are more consistent with sports medicine injuries? How do you help decide what goes into that box when space is so limited?
Okay. This seems like a daunting task.
It really does.
at your level. But this is why NASA's our space medicine philosophy actually makes it kind of simple. And that is, it's all about screening out disease.
Okay.
And our astronaut selection really helps us with that, because if you haven't bought disease, in other words, you're flying just very, very healthy people, your mass, power, volume, time, money footprint is actually kind of small.
Okay.
You don't have to fly an intensive care unit capability up there. So that being said, I mean, common things occur commonly, right? That's the mantra in medical school. If you hear hoof prints, look for horses, not zebras, right? So, things that occur commonly, we will do periodically, every couple of years, we'll kind of do these data scrubs among the operational flight docs about what are the medical conditions we've seen in space. And we kind of go by and do like a Delphi technique, where we'll kind of look at all these things and we'll kind of go down. And when you look at what happens in space, by and large, it's kind of the same thing by system. Musculoskeletal things are number one: minor aches, pains, low back pain, space adaptation, back pain, blah, 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 blah. Foreign bodies in the eyes, dry mucous membranes is a dry environment, 38% humidity, rashes related to dryness or other things, we don't really know. Nasal congestion, but it's not allergic. I've come to a conclusion after treating multiple crew members that it's a vasomotor rhinitis, and they've responded very well to topical azolastine and steroids. Okay. Because of all the ventilation flow and different things, and I think there's a higher mold content in parts of the station, and some crews react to that and different things, and blah, blah, blah. So you just look at, well, what are all the things that crew have experienced in space, and then let's just prepare our med kits and our diagnostic stuff as around the things that we see. Yeah. Okay. But the other part of this is a lot of your medical risk can be engineered out of your design, and that's something, again, you don't learn in medical school unless you've been an engineer first. And the best example for dumb guys like me is, if you have sharp edges in your space station, you get a pretty high risk of a laceration. Yeah. So you better have a laceration kit and all these other things associated with wound care. If you make sure that there are no sharp edges, well, you just drastically reduce your risk of cuts and things like that. And that's what we've done. So smart engineering design for the human in the loop actually reduces your risk for a lot of this stuff. Yep. So I greatly oversimplified something that's very large and complex, but that's kind of at your level an understanding of how we kind of do things. And we got 5 decades of experience, and that philosophy actually kind of really works. Screen out disease. Don't fly bad stuff. If you decide you want to fly, patients who have diabetes and, coronary artery disease. I mean, knock yourself out, do it.
Right.
But you better have the ability to treat all the things that go along with those things.
Right. Yeah.
If you don't have the mass, power, volume, time, and money to
Mhm.
do that, then you probably better screen that out and just fly people who don't have a lot of risk. You're always going to have orthopedic stuff,
Right.
minor stuff. You're always going to get foreign bodies in the eyes because stuff floats,
Right.
but it's not a big deal.
Gotcha.
You're always going to probably have rashes because,
Mhm.
again, they just get
Right.
rashes up there. But, if it's wet, make it dry. If it's dry, make it wet, kind of. Occasionally, we've had urinary retention and had to do straight caths.
Hmm.
Okay, so all the astronauts get trained on how to do straight caths and different things like that. And what's happened more recently is, we've had more orthopedic conditions that I've actually utilized ultrasound to look at the carpal tunnel or the cubital tunnel or Guillen's canal or the spine, the anterior cervical spine, or the posterior, the stabilizer muscles. I think I know we're going to be doing more and more and more ultrasound to learn what space normal anatomy is, to start figuring out how to use that as a diagnostic tool. And but we got the butterfly IQ now. You got an ultrasound device that has great resolution, great functionality, very user friendly, and takes up virtually no mass, power, volume. So anyway.
And so the last question I'll kind of get into.
By the way, that was a really good question.
Oh, thank you. The last question I'll kind of get into is about kind of muscular decompensation in space. So your muscles are kind of atrophying a little bit. And now I'm just kind of imagining, let's say we're going to the moon. You have astronauts, as you were saying, where administration really wants to make the most of the time. They want all their astronauts to go and do a bunch of great stuff. But you have muscle atrophy as a factor, right? And so exercise equipment on the space station has evolved and become more sophisticated. But as the ambition increases, as missions on the moon and in the future to Mars become increasingly viable, how do you kind of see exercise physiology and the need for exercise equipment on the space station or space shuttle kind of changing? Like, is that going to need a further evolution? Does that need to be explored more, or what's that like? Because I personally keep running into papers talking about, okay, there's muscle atrophy. We need to find a way to work around it. There's been a lot of work to counter it. Are those measures going to need further evolution and further progression, as activities increase and strain on the astronauts kind of increases for moon missions?
Yes.
Okay. I figured, but
there's a couple aspects of it. Our current suite of exercise countermeasures, the advanced resistance exercise device, the ARED, the T2 treadmill, and the cycle ergometer, the CEVIS, are very good at maintaining bone density within 8 to 10% of pre-flight DEXA scores, muscle mass and strength single digits, VO2 max within single digits. They're really good. And we know from a human performance optimization standpoint, keeping them at that level of fitness not only enables them to do their nominal job well, going out doing spacewalks, returning to Earth, but also if they have to do contingency, emergency spacewalks of a longer duration, the more fit you are, the better you're going to be able to do that. All that plays into that. But there's always the desire, because again, everything we do in space is run by mass, power, volume, time, and money, to make things smaller, more compact, but have the same capability. So we did a down select of an exercise device. I don't think I can go a lot of detail on that because it's kind of proprietary, but bottom line is we had a design that kept our current exercise requirements for resistance, aerobic, but we're able to just downsize into a much smaller compact device. And that's what you're going to need in Orion, where you don't have a space station size capability, but you still have a work envelope. You have to be able to do overhead press. You still have to be able to do rowing. You still have to be able to do these things but it's a much smaller volume. So the desire, I think, from all the data we've learned on station is, if you really want to keep your crews in its best shape for all the reasons I mentioned, and eventually get them to planetary surface operations, which again, that's a big question mark out there. You're probably going to have something very similar to what we have right now, but if there's a way really smart engineers can make it smaller, more compact, reduce mass power volume, but yet allow them to keep within the single digits of bone mass, muscle strength, aerobic capacity, and stuff like that, that's going to be a winner. And I think most all of us, because we're always thinking about contingencies, the off nominal, the emergency things, being able to have it. Now, granted, death is a good motivator. So if you're going to die, if you don't fix this bolt or do this thing, that's probably a good motivator. But boy, at least give your guys a fighting chance by being as strong and having as much stamina and dexterity as they can get through your exercise devices. The additional thing that, and this is a thing that gets lost when you talk to the engineering community, but I think it's as important as any of the physiologic measurements you can do for strength, endurance, is the fact that the crews like it.
Yeah.
It's time that they just kind of get their minds off their busy work schedule. Like for those of you in the audience who exercise, you're like, yeah, that's kind of my drug. That's my thing. That's my escape. And the crews like it. And go back to Apollo. Apollo's like, yeah, they really like doing this for 45 minutes. I mean, good grief, how boring can that be? But you broke a sweat, you increase your heart rate. Exercise is good. It makes you sleep better, makes you eat better, it makes everything better. So that's been my push to the program, because again, the program's looking at mass power, volume, times money. And like exercise takes up a lot of volume, takes up a lot of I'm like, yeah, but put your money where your mouth is. You're going to get a lot out of that, especially for the 8.5 month transit to Mars.
Yeah. And I was going to say that ties into the psychological aspect, which, maybe also gets lost for engineering when communicating with the engineering side, is you have to enjoy the exercise you do. You have to enjoy the crew you're working with. You need to, if you're going to be in a soup can for a few months going to Mars, you need to be psychologically sound. And I think exercise and even just the design of the capsule and all that really plays into that. I remember one thing that we had learned before was the colors that are chosen inside really helps to kind of aid and boost psychological factors, helps boost your mood, keep you a little bit more alert. So great. Yeah, it's really good to hear. I was trying to think. I had one more question, but I can't think of it right now. Oh, yes. So a lot of what we discussed is very exciting in terms of progressing our capabilities in space, right? Making sure our astronauts are fitter, they're able to accomplish their objectives. Could you share a little bit about how what's discovered and the research that's done at NASA can be applied down to Earth for your patients here on Earth, maybe some of the findings that you're able to share?
Best example I can give you, and this goes back to my years as a private practice doc, the number 2 medical condition any family doc, sports medicine doc sees in their clinic is low back pain.
Okay.
If you look at the data, epidemiologic data for workman's comp or whatever, low back pain, tens of billions of dollars in lost wages, hours, etc. Astronauts' spines change in space. They grow 2 to 6 centimeters because they lose lordosis in their cervical lumbar spine. If you're an astronaut, you fly in space, when you return, you're 4.3 times more likely to have a disc herniation in the lumbar or cervical spine. Something changes. So our team, part of an investigation team at the University of San Diego and San Francisco, and currently teams that are looking at the spine changes, are getting really smart on pain generators. There's 9 nociceptive tissues in the lumbar spine. I mean, which one sends the pain afferents to your thalamus? Is it the vertebral end plate? Is it the vertebral body? Is it the nerve itself? Is it the annulus? Is it the myofascia? I mean, what is it? I don't know. Well, we're starting to get really smart about pain generators because we have a very healthy patient population that does not have concomitant, disease.
Mhm.
They're not smokers, they're not drinkers, they're not obese, et cetera, et cetera. They're, the injured, motivated crowd. They want to get back to work. They don't want to malinger and stuff like that. So we've got a really unique patient population, kind of like military population.
Right.
And we're starting to get really smart on the spine. I'm passionate about making sure that taxpayers get a return on their investment.
Right.
So years from now, God willing, we get really smart on how to better diagnose and treat low back pain in astronauts. I'm taking that to my, ACSM meeting, my AMSSS meeting, my AAFP meeting, whatever. I'm saying, hey, we can use this and you can help your patients in your clinic, your assembly line workers at John Deere, this, that, and the other, and actually develop better preventive strategies and all these other things because we've done this and it works for astronauts. And, I think that's a great success story. We're not there yet, but we're getting a lot smarter. The only problem for us is our patient population is so small, but it's a pristine population that doesn't have
that's really
confounding
good to hear that there are
variables.
applications that can be transferred over.
Yeah, I mean, there's all kinds of other stuff out there, but my particular areas of interest and research, and especially because on the military side, cervical and lumbar spine are huge in the pilot flight surgeon community in terms of just wrecking spines because of high G, vibration in helicopters, stuff like that. And a lot of our astronauts are former military high performance jet aircraft pilots or rotary wing pilots. I want to get smart on this because I want to be able to help them. But then this will trickle down and be able to help other folks. So I think we're years from being able to translate our research from space into what can help, the everyday doc in the clinic and, wherever, but we're going to get there. And I think that's pretty cool.
Yeah, and that reminds me, I mean, one of the previous interviews we had, there was some discussion about, again, muscle atrophy in zero G and being able to apply some of the countermeasures that are used in the space station for patients on Earth that are bedridden, maybe after an accident, or maybe they're in hospice, and applying some physical therapy countermeasures to help them out. And I thought that was really interesting. It's always really interesting to hear how, this space medicine research can be applied down to Earth and help people on a day-to-day basis one day. So it's really exciting as well.
Well, again, I'm an American taxpayer. I want to see a return on my investment. I'm funded as a civil servant by the American taxpayer. So I want to make sure you're getting something for your tax dollars. And I think we're slowly but surely, I mean, besides the wow factor, everyone gets inspired by space. Right. It keeps kids in school. It just makes them strive for STEM, and stuff like that. I mean, that's cool. But the practical applications in medicine, I think we've seen over the years with understanding better and better applications of exercise and how you can actually specifically train certain muscle groups and do different things in paralyzed patients, different patients who are analogs to microgravity. And I think we've learned from that. But this back and neck thing, I think that's a winning lottery ticket. We're just not there yet. We got enough smart people working on it. And that's going to be a big deal.
Very exciting. In due time.
Yeah. And everything, this is the crazy thing when I think about, when people say, NASA, it's too much money, blah, blah, blah. When I start rattling off all of the technology that everyone in America uses every day and has no clue that it actually originated from the space program.
Yeah.
They're like, oh yeah, maybe space is a bad investment. I mean, you think about it, our mass power volume time can make us develop things that are really, really, really innovative. Great example, 1966 Gemini program. NASA teams up with Nabisco to come up with a high-calorie, palatable, compact, long shelf life food source, and that was the precursor to the Cliff Bar, to the Power Bar. Nice. Came from the space program because we need to have something like that in space, and Nabisco's like, dang, cool, got it.
We'll take that.
Hook and loop fat fasteners. Now, most people don't know what a hook and loop fastener is, but they would know what Velcro is.
Right.
NASA didn't develop that, but they put out the requirement for having some type of reusable, type of device to secure astronauts down. Private industry took that and said, boom, let's come with hook and loop fasteners. Velcro, everybody uses Velcro.
Yep.
Water disbursement 40. Where did that come from? So the Mercury capsule was getting all this condensation on the windows, and someone was developing a water disbursement device that you could spray on to keep the water out of that. Also figured out it was a great lubricant. That's where WD-40 came from.
WD-40, yep.
So all these different things, where does telemetry that's used in every single intensive care unit, every medevac unit came from? That came from Gemini.
Right.
Because we had to have that with astronauts circling the Earth.
Right.
So the space program, it poses problems that passionate, smart people who can think outside the box say, hey, I think I've got an idea for that. But it's because we have really hard problems to solve in space. And then industry takes it and then they do it, and all of a sudden, boom, everyone benefits from that.
Yep.
So, I mean, this is kind of like a no-brainer.
For sure.
For if you really want to dig down and think about it. And the things that are going to come from Mars, again, thinking about how do you do Mars with mass power volume time, the way things are going to look for everyday life in America in 2040, so much better because of what we're going to do to go to Mars. I can't, but I can't even think of it, but I can know it's going to happen.
It's going to happen. It's not even that far away too. It's another 18 years, and
I'm getting close to pushing up daisies by then, but you will do it. And you're great.
sooner rather than later. I was gonna say, I mean, I made the sin, let's call it, of asking that very question to a former NASA employee a few months ago, and he had a very robust response. And one of the cool things he mentioned was one of the finishes that they use on eyeglasses, anti-glare, apparently came out of one of the space programs, and I use glass every day. I've been using glasses since I was 7 or 8. Didn't even know it. Just don't really think about these things. So it's really cool.
Yeah.
Well, I'm out of questions. So thank you very much for your time. Lauren, do you have any questions for Dr. Scheuring here?
I'm all set. Thank you.
Yes. So
You're still awake, Lauren? Didn't put you to sleep?
No, it was very interesting. Thank you.
So thank you very much for sharing your time with us. It was really interesting to get your perspective and get fired up about space and space medicine. So thank you again for sharing your time, and it's been very, very informative.
Hope your your future generation of flight surgeons, got something useful out of it. And like I said, speaking only for myself, but I know when I drove around NASA and realized I was a NASA flight surgeon for the very first time, and thinking about the legacy of following the footsteps of Chuck Berry and Bill Carpentier, and wow, that was crazy. But if a guy like I can do it, anybody can do it. And I'm not being self-effacing. I'm just like, it's really true. There's nothing special about me, but I've got a good work ethic. I'm tenacious, and I don't take no for an answer. And those are things that get you far in life, no matter what you do. So figure out those things, figure out what you really like, get passionate about, get really smart, and then show NASA why you need it.
Great.
Well,
yeah, it's really exciting. I mean, Lauren and I are currently poised to enter medicine very soon. So it's very interesting and very kind of hopeful to know that we are on the path potentially to become flight surgeons of our own, or provide something for the space community, which is something that we're very passionate about. So
yeah.
All right. To look forward to. So thank you very much.
And you say your name, Gautam?
Gautam.
Gautam.
Gautam. Yeah.
Gautam. All right, Gautam. Listen, it was a pleasure. Always stay in touch, follow up, got questions or whatever.
Absolutely. We'll do.
All right. Thanks for spending your time.
Yeah. Bye-bye.